Hi, my name is Dr. Ed Shahady, and we're here at the Cardiometabolic Risk Conference in Las Vegas, Nevada. And I'm here with Dr. Joel Heidelbaugh. He's a professor of Family Medicine and Urology at the University of Michigan. And he's going to be talking here in a few minutes about testosterone replacement, some of the pros and cons, which I look forward to hearing. Joel, what we read in the paper or see ads on TV about some of the downsides of testosterone. How do you respond to that?
Well, Ed, I think if you go back about 5 or 6 years ago in the media, there was a lot of push through marketing about getting men interested in asking their doctors about testosterone and really trying to see what all that means relative to their overall health. In recent years, there's been some studies that have suggested some risk of cardiometabolic disease and cardiometabolic outcomes. Today we're going to talk about those papers and studies, and we're going to talk about some of the flaws in those papers. We'll also talk about some of the pros and cons overall of testosterone replacement therapy and what that means for cardiometabolic syndrome. Okay,
so I'm sitting with a patient, and when should I think testosterone? I know some of them will bring it up, but when should I, as a clinician, think about testosterone replacement in this patient?
I think in any male patient, it's good to take an overall cardiometabolic risk profile. It's also good to take a complete sexual history and try to correlate whether a man feels fatigued, whether he feels he's had decreased stamina, whether he has any type of decline in his sexual function or libido, but also taking a look at what his cardiometabolic risk factors are, whether or not he's diabetic, what his family history is, whether he has other endocrinologic abnormalities, and summarizing it that way.
Okay, so if he's got cardiometabolic risk, I should evaluate his testosterone level.
So I wouldn't say in all patients, but I think if someone is overweight, has a lot of visceral adiposity, certainly if they're making attempts at weight loss and not being successful, coupled with a lot of the other symptoms I mentioned with sexual dysfunction, fatigue, it's reasonable to consider screening them for low testosterone.
So they're phenotypically, other issues, hypertension, et cetera, plus the symptoms you mentioned.
Sure.
Okay, is testosterone just plain old simple testosterone level, or are there special tests we should get for it?
So right now, the Endocrine Society guidelines posit that we should check a first morning testosterone, and arbitrarily the number was cut off, the cutoff for low was set at 300. So you have to couple that with symptoms. You have to couple that with whether or not a man has the symptoms I mentioned. And generally 2 values on 2 separate occasions, less than 300. I don't necessarily say that, for example, a man has 2 values of 297. I wouldn't necessarily start that man on testosterone. There's a lot of other things that could be done in terms of diet, exercise, weight loss, and improving overall cardiometabolic risk through diet and exercise. But I do see a lot of men who come in with fatigue, poorly controlled diabetes, all the metabolic syndrome equivalents, and their testosterone is 100. They may be on other medications that are lowering testosterone, and they may have primary or secondary causes.
Okay, what if the complaint is, Doc, I have sexual troubles. I'm not a man anymore. Why testosterone versus some of the other agents that are used for erectile dysfunction?
So oftentimes, when taking a complete sexual history or screening a man for sexual dysfunction, it's important to look at their cardiometabolic risks. It's important to take a look at their entire medical risk profile. It's also important to get a sense of their psychosocial well-being. We do use a lot of phosphodiesterase type 5 inhibitors, and those have their role in improving sexual function as well. There is some conflicting literature on whether or not replacing testosterone may improve sexual function.
Okay, so that shouldn't be, if that's all they have, that's not a reason to give testosterone, especially if their level's normal. You want to comment on that? Because I guess that some people were getting testosterone without even measuring a level, having normal testosterone levels. I think you comment on that in your talk.
Correct. So there is a study from a number of years ago that showed that about 1 out of 5 doctors who write testosterone prescriptions were doing this without checking testosterone levels. And again, I think there are some cutoff levels set by the Endocrine Society, but those have to be coupled with the entire risk panel and symptom profile. I wouldn't advocate for just having a man say that he has certain symptoms, and then starting him on testosterone.
Okay, so you do a good evaluation, not only symptoms, but laboratory evaluation, and look at alternatives, I understand. And I guess if they do lose weight, their testosterone level may come up.
In some men, that's actually true. If they can lose some visceral adiposity, they can avoid having to take testosterone supplementation. We see that in clinical practice.
Okay. Well, what about how do I give testosterone? There are patches and pills, and so what's the best choice, if there is a best choice?
I don't know if there's a best choice. I think there are a variety of options. I have to say that right now, especially with a lot of the literature that's come out, certain insurance companies have declined covering these medications or have placed great stipulations on covering these medications. So the best one may be the one that you can actually get covered unless the patient wants to pay out of pocket. There are some advantages and disadvantages to each, which I'll talk about in the lecture. The advent of the topicals really came out relative to providing a mechanism in a vehicle where there's a steady state of delivery and you don't have greatly fluctuating serum profiles.
So I guess what I need to do, it's not only for testosterone replacement, but any medication, will their insurance company pay for it? So I got to have good staff that will really check that out for me and then offer that to the patient.
It's often an issue. It's often an issue. I think it's going to depend state to state and carrier to carrier. And
absolutely, because I'm in Florida, what's approved in Florida may not be approved. It may be Blue Cross Blue Shield in both places.
Correct.
Great, Joel. I appreciate it. Excellent information. I look forward to hearing your talk.
Thank you very much.